informative discussions with some really good discussion and feedback. My name is Donna Leckie. I'm head of the Primary Care and Interventions Unit at UK Health Security, and my team lead on the Target Antibiotics Programme. So this is our 8th webinar in the series that we've done with the RCGP. And in this webinar, we're going to be focusing on applying diagnostic and prescribing guidance of urinary tract infections. And we really hope to meet your expectations and need through this webinar. The format this evening is going to be the same as previous webinars. For those who've attended any of our previous webinars, you will know that our speakers will present for around 40 to 45 minutes, and then we'll have 15 minutes at the end for dedicated Q&A discussions with our panelists. Panelists are going to field questions through the webinar, so do please feel free to add in your questions as we go along, and we'll respond to specific questions at the end. I just want to flag up some housekeeping. So please do ask questions throughout the presentations using the Q&A function on your screens. So on your Zoom screens, use the Q&A function. Like I said, you don't need to wait to the end of the talk. Just ask questions as they come to you. And we've got a group of people here in the background who's actually fielding those questions. We'll try and get through as many of them as we possibly can. If you wish to ask your question anonymously, please tick the anonymous box before submitting the questions. Like I said, we'll answer as many as we can in the allotted time, and any that we can't answer, we will put up on an FAQ on the RCGP website when we launch the webinar. Panelists are invited to provide written replies and tag some questions to answer verbally during the Q&A session at the end. So if you don't see an immediate reply, it might be because we're flagging it for a discussion point at the end. Speakers and panelists will not be responding to the raise the hand function. Just to let you know, we actually cannot see it this evening. So do please type questions into the Q&A box. This webinar will be recorded, and the recording will be uploaded onto the Target Toolkit. Now, by the time all of this happens, it takes a few weeks, so it'll take about a month before it's actually live on the website. You will be sent a link with a brief survey evaluation directly to your email shortly after the webinar. Please do help us by improving our webinars and by filling this out. It really gives us lots of information about, excuse me, what you want from these webinars and how useful you're finding the information. So this is your opportunity to tell us what you think and what you need. Next slide, please. I just want to say that although I'm speaking, I am speaking on behalf of a team here today. These people on the slide are the people who are actually doing the work. So a big thank you to Liam, Lizzie and Emily. You won't see them during the webinar, but they've really worked together, the RCGP and the Target team, to pull all of this together. So a big thank you to those. Next slide, please. So here is a slide with our amazing speakers and panelists. I want to say a massive thank you to our speakers and panelists for supporting this event. Without them, we couldn't have the webinars the way that they've been. So the first person speaking today is going to be Dr. Philippa Moore. She's a consultant medical microbiologist at Gloucestershire Hospital NHS Foundation Trust. Our second panelist and speaker is Elizabeth Beach. She is a regional antimicrobial stewardship lead for the Southwest region at NHS England. And then to move on to our panelists, we have the wonderful Naomi Fleming, who is the regional antimicrobial stewardship lead for the East of England region in NHS England. Next, we have Avril Tucker, who is an antimicrobial pharmacist in NHS Wales, and Avril has been absolutely amazing at supporting us in webinars and with developing some of our target tools. And last but by no means least, we have Dr. Lee Saniolu, who is a GP and doctoral fellow at Cardiff University, who is extremely knowledgeable in the area of UTIs as well. So look forward to hearing the panelists field the questions. Next slide, please. So in this webinar, we want to go through some of these aims. This webinar theme was chosen based on feedback from users requesting webinars focusing on the clinical management of infections presenting in primary care. And through the webinar, we will use the clinical scenarios for UTIs to refresh our knowledge and management on these conditions, covering national management guidelines, as well as newer guidance and decision tools that are being applied in practice. So our aims are through the webinar, we will discuss antibiotic resistance rates and trends linked to urinary tract infections. We'll capture and discuss ways to assess prescribing trends for your practice and locally. We'll identify and discuss national diagnostic and prescribing guidance specific to the management of UTIs in different patient groups, and we'll utilise evidence-based strategies and resources when discussing antibiotics with patients in the context of UTIs. So Philippa is going to talk through the webinar through all of this, and then directly following that webinar, we'll have a talk from Elizabeth Beach on data management for improvement. So without further ado, I'm going to hand you over to Dr. Philippa Moore to start the webinar. Thank you, Philippa.
Thanks, Donna. So to start off with, the challenge of antimicrobial resistance. I'm sure you're all already aware of the issues associated with antimicrobial resistance in your daily practice. However, on a global scale, the recent UN report in April 19 highlighted that by 2050, AMR, antimicrobial resistance, could kill 10 million people per year in its worst case scenario, which reiterates the O'Neill report from 2016. And this, in this graph you can see, is more than diabetes and cancer combined. And this will come at a cost of £66 trillion. While we know that antimicrobial resistance needs to be addressed through the many different social and environmental factors that contribute to it in a One Health sort of way, a lot of important work is going on in different sectors. We know that humans are the largest consumers of antimicrobials in the UK. 2/3 of all antibiotics were in humans in 2019. So improving how infections are managed in our healthcare is a key step as we work together to reduce resistance. The other 1/3, if you're interested, is for use in animals. And so that's an interesting consideration, 1/3 to 2/3. So what does that mean for us? We know that over the past 5 years, most antibiotics used by people in England were prescribed in primary care, about 80% in 2022. This data is from the ESPA report, which is the English surveillance programme for antimicrobial utilisation and resistance. The drop in consumption in 2020 and 2021 related to the pandemic should be looked at in isolation, and we're seeing a return to similar prescribing as in 2019. This is expected, but it is something to monitor going forward. Again, a similar pattern for overall prescribing, and we have seen a gradual fall in antibiotic use for some years since 2014. And again, noticing the impact of the pandemic and a resulting increase in 2022. Although some of this increase was related to lower thresholds for prescribing for suspected group A strep in the winter of 22, urogenital tract infections account for approximately 1/4 of prescriptions for infections provided in primary care, highlighting the importance of addressing prescribing for this group specifically. So moving on to a clinical scenario for urinary tract infection. So what should we think about? If we consider the following patient details: a 35-year-old with strong smelling urine, dysuria over 2 days, frequency, recent laparoscopy and removal of endometriosis, and had trimethoprim in the past month for suspected UTI post-op. What sort of things might we want to ask about in a patient like this? So we might want to ask about other non-UTI symptoms, things like vaginal discharge, other GU symptoms, relationship to intercourse and sexual contacts, symptoms of pyelonephritis such as loin pain, rigors, fever, and find out some more about the symptom severity as well as the duration. There may be other urinary symptoms like nocturia or hematuria, and there may be risk factors for antibiotic resistance or infection, such as what other antibiotics they may have had in hospital, whether there are any peri-op complications, other recent antibiotics for other reasons, or travel to countries with high antibiotic resistance rates. So these are just examples of sort of further information that you may want to gather when considering what sort of treatment you would prescribe in this sort of clinical scenario. So UKHSA publishes a quick reference tool for diagnosing uncomplicated lower UTI in different groups, including women under the age of 65 years without a urinary catheter. This is a snapshot of the design, last updated in October 2022. The content of the tool is currently out for review, and we're looking for feedback from a user perspective, and the link will be shared by email. So I'm going to walk you through the flow chart section by section. Okay, so first of all, to note, it excludes women with recurrent UTI, which is defined as 2 episodes in the last 6 months or 3 episodes in the last 12 months. Also excludes women with urinary catheters. It will be suitable for some women over 65 years in the community setting, which I'll come back to. So firstly, to note that we do not treat asymptomatic bacteriuria in non-pregnant women, as it does not reduce mortality or morbidity. And then the first box is to think about, actually, are there any other causes, such as if there's a vaginal discharge, 80% of women would not have a UTI. So asking about vaginal and urethral causes of symptoms, urethritis, inflammation, post-sexual intercourse irritants, sexual history, and genitourinary syndrome of menopause. So if any of those apply, then UTI is not the most likely diagnosis. If none of them apply, then the next thing is to think about sepsis. So this is safety netting. Are there any signs or symptoms that suggest pyelonephritis or sepsis, in which case you would want to start urine for culture and immediately start antibiotics as per the NICE guidance for upper UTI or sepsis, and potentially refer if the symptoms are serious or there's evidence of serious illnesses. So assuming that it's not a gynecological infection, it's not a sepsis, we then get into the main part of the UTI diagnostic tool. So does the patient have any of the 3 key diagnostic signs and symptoms? So this is evidence-based questionnaire, if you like, that asks the question, these are the most highly associated symptoms or signs in the case of cloudy urine associated with UTI. In the Target website, there is more information about the evidence behind this. The 3 key symptoms were based on a validation study using clinical scores and urine dipsticks from Little et al. In 2010, included 434 women with at least 2 urinary symptoms of UTI and no vaginal discharge in 62 different primary care practices in England, and the positive predictive value was very strong for clinical symptoms of dysuria, nocturia or cloudy urine, and dipsticks, but had poor negative predictive values, performed slightly better, but with poor negative predictive values. So the findings showed that patients with suspected UTI who have dysuria, nocturia of any severity and cloudy urine probably do have a UTI. So this is this first section here. And a dipstick is not needed for these patients. It's likely that this patient does have a UTI. So this then takes you down to the box where you should send urine if there is a risk of antibiotic resistance. If they are not pregnant and mild symptoms, then consider a watch and wait with a backup antibiotic, or consider immediate antibiotic, especially if the patient is pregnant. And for all patients, we should share self-care and safety netting advice. And there is a Target UTI leaflet, which has the information that's necessary. Note that if the patient is pregnant, always send a urine culture and follow the national guidance. So then going down to the next box, if there's only one symptom of these key symptoms, then this would be the time to consider performing a urine dipstick. And then obviously when reading the test, follow the manufacturer's recommended timing and instructions. If there is a positive nitrite or leukocyte and RBC positive, then UTI is likely and the same applies. But if there's a negative nitrite, a positive leukocyte, then UTI is actually equally likely to other diagnoses. So have a look at the time of the specimen. Morning urines are more reliable. Consider sending a urine for culture to confirm a diagnosis, and immediate or backup antibiotics if not pregnant, depending on symptom severity. If there are none of these key symptoms, then are there any other symptoms usually associated with UTI? So urgency, visible hematuria, frequency, suprapubic tenderness. If there are not, then UTI is less likely. If there are, then again, using a dipstick to improve the predictive value is what is recommended. And if there are no symptoms, then no urine culture unless pregnant, reassure that UTI is less likely and consider other diagnoses. That doesn't stop the opportunity for giving out safety netting advice and the Target UTI leaflet. And in particular, this has information about the importance of hydration. So one thing that will potentially change in the updated flowchart is the information about when women may have blood in her urine, but negative nitrites or leukocytes. So watch out for that. And there are studies that have more details behind all of this. So what about the treatment? What about those at high risk of asymptomatic bacteria, like older adults and those with a urinary catheter? So the treatment of UTI in older people should follow the same principles as in younger patients and should be based on whether the infection is uncomplicated or whether there is evidence of pyelonephritis or bacteremia. Empirical diagnosis of UTI in delirium for residents who do not have an indwelling catheter, minimum criteria for initiating antibiotics might include acute dysuria alone or fever, increase of at least 1.5 degrees C above the baseline. Or at least one of the following of new or worsening urgency, incontinence, frequency, signs of irritation of the urinary tract such as suprapubic pain or flank or loin tenderness or gross hematuria. A positive urine culture or dipstick test will not differentiate between UTI or asymptomatic bacteria, and there's no robust evidence for the use of LE leukocyte esterides to test for leukocytes or nitrite by urine dipstick testing in women aged 65 and over in long-term care facilities or in frail elderly people requiring assisted living services. Patients with asymptomatic bacteria may also have white blood cells in the urine, as white cells may be there in response to the presence of bacteria. But if the patient is asymptomatic, there's no evidence that antibiotic treatment will benefit the patient or prevent, for example, the development of UTIs. Now, there are many studies looking at the use of urine dipsticks, and as a generalization, they have a better negative predictive value for older adults, but there are variable results across different studies and risks if UTI is discounted, particularly in vulnerable patient groups. For this reason, the QUISP reference tool does not recommend their use to rule in a UTI or to rule out a UTI in older adult groups. UTI should be considered if there are signs of septicemia and generalized illness, nausea, vomiting, rigors, new or increasing malaise or confusion, tachycardia, tachypnea, poor peripheral circulation, reduced urine output or low blood pressure. And for patients with recent hospitalization or antibiotics, consideration should be given to the prescription of pivmecillinam, coamoxiclav or ciprofloxacin over trimethoprim, and that's due to resistance. But if these are all prescribed, always safety net and send a urine specimen for culture and sensitivity so that the treatment can be modified on receipt of the culture result. So a systematic literature review covering quantitative primary care studies assess the urine dipstick as tool in diagnosing UTI was conducted by Erickson and Bing Johnson and published in 2015. This review summarised 6 studies that looked at urine dipstick use and the correlation to positive urine culture, and the authors found there was a positive predictive value of leukocytes and nitrites on a urine dipstick ranging from 31 to 93% and an NPV, negative predictive value, ranging from 49 to 100%. So you can see there's a really wide range actually. The authors conclude that dipsticks are more useful for ruling out a positive urine culture than in, but summarise a number of limitations that clinicians need to be aware of, and to highlight reasons why dipsticks may give a false positive or negative group in the result in this group. And there are a number of different cultures that studies that show similar results. So the Target website also links to a UTI quick reference diagnostic tool, which is hosted on the UKHSA website. This is a snapshot of the decision-making algorithm for women over 65. This was last updated in October 2022. So this flowchart currently combines recommendations for adults over 65, and I'm going to walk you through the flowchart section by section. Just a note, although the age of 65 years is used to represent the cutoff for the risk of asymptomatic bacteria, there's a lot of discussion about whether or not different criteria, for example, frailty, should be used, as the research that underpins the recommendation is quite old. UKHSA at the moment is currently working with the University of Oxford to review the data and see what evidence there is to move the cutoff for age. But for the moment, we're continuing to recommend the age of 65 and note that discretion may be needed if considering women who are fit and healthy and living in the community. Okay, so in terms of the box, first of all, we're considering urinary signs and symptoms, abnormal temperature, and non-specific signs of infection. In this age group, we're not recommending the use of urine dipsticks. Dipsticks become more unreliable with increasing age over 65. And by 80 years of age, half of older adults in care and most with a urinary catheter will have bacteria present in the bladder or urine without an infection. This asymptomatic bacteria is not harmful, does cause a positive urine dipstick, and antibiotics are not beneficial and may actually cause harm. Presence of nitrites, just to note, is there for most bacteria. The false negative may occur with enterococci, but there's a real question over what the role of enterococci is in the etiology of UTIs anyway. Okay, so firstly, we need to consider genitourinary syndrome of menopause, otherwise what we used to call vulvovaginal atrophy, urethritis, STIs and prostatitis. Again, think of sepsis, safety netting from the point of view of these patients may need to more immediate action if there is evidence of pyelonephritis, so renal angle tenderness, and myalgia, nausea, vomiting, or rigors, or a measured pyrexia or hypothermia. And in this case, we would consider sepsis or pyelonephritis, send a urine for culture before antibiotics are given or taken. You would start immediate management with antibiotics for UTI, again using the NICE guidance, or there may be local guidelines as well for sepsis, considering resistance risk depending on where you're working. If there's a urinary catheter, consider removing that or changing as soon as possible, preferably after the first dose of antibiotics is given, because there is a bacteremia that happens with manipulation of a catheter, and refer if symptoms are signs of serious illness. Another tool that you may see used more frequently in care homes is the Restore2 tool, which is based on News2 but is modified for use in early detection in care home settings. So just to be aware of that. So like women under 65, symptoms are key to diagnosing UTI in older adults. The symptoms for UTI in older adults are slightly different than those for younger women based on the findings from different studies. So research targeting women at their homes in the community shows that menopausal and postmenopausal women report on increase in symptoms like nocturia and incontinence when compared to premenopausal women. So a cluster randomized controlled trial in 24 nursing homes, for example, in US and Canada in 2005, 12 care homes were allocated to a multifaceted intervention and 12 to usual care for a year. And diagnostic and treatment algorithm was implemented in the multifaceted intervention. And the key symptoms identified for those with a urinary catheter were one or more of costovertebral tenderness, rigors, new onset delirium and fevers. And for those without a urinary catheter, dysuria or 2 or more of fever, urgency, flank pain, incontinence, rigors, frequency, hematuria and suprapubic pain. And fewer courses of antimicrobials were prescribed in the intervention nursing homes than in the non-intervention groups, which was significantly different. And there was no difference in hospitalisation or mortality. Okay, so we're looking at new onset dysuria alone as being the most key symptom here, and 2 or more of either a change in temperature, new frequency or urgency, incontinence, delirium, debility, new suprapubic pain, visible hematuria. And if there is a urinary catheter, consider whether there is catheter blockage, which may show, of course, as bypassing, and consider removal or replacement. So if these are present, then a UTI is likely, and in which case the advice is to share the self-care and safety netting advice using the Target UTI leaflet. Always send urine culture if feasible before antibiotics are taken, as resistance is greater in older adults. If the symptoms are very mild, consider backup antibiotics in women without catheters and with low risk of complication, or offer immediate antibiotics using the NICE guideline on lower or catheter-associated UTI antibiotics. If the urinary catheter has been present for over 7 days, consider changing. If possible, remove as soon as possible, but do not delay the antibiotics. It's best to give the antibiotics at least 1 dose first, and review the antibiotic choice and culture result using narrower spectrum antibiotics if possible when the results are available. So in this group then, check for other causes of delirium if it's relevant, and using the acronym PINCH-ME, so P, pain, other infection, poor nutrition, constipation, poor hydration, other medication or environment change as causes for delirium. Check all, and if there are, then obviously give safety netting advice and reconsult if there's worsening symptoms or no improvement 48 hours after starting antibiotics, or if there's signs of pyelonephritis or sepsis. Check also for other localizing symptoms or signs, so symptoms, for example, of respiratory tract infection, GI infection, skin and soft tissue, which would obviously prompt different treatment. And if there is not, then advise watchful waiting with further investigation for other causes, obviously considering antibiotics if things deteriorate. So why do we need to worry about our antibiotic use for UTI? So UTIs are linked to bloodstream infections and resistance. The yearly estimated burden of E. coli resistant bloodstream infections has reduced from 2017. However, there is still more work to be done. E. coli are the most important cause of bloodstream infections that are resistant to antibiotics, and there are different estimates, but approximately 51% of E. coli bloodstream infections are potentially linked to the urogenital tract. That's from a particular reference that was used for this. However, there is a lot of consideration about where, because it's not always possible to tell where E. coli UTI comes from. Some people estimate that it could be higher than 51%. After respiratory tract infections, UTI are the most prescribed for infection in primary care. So this data is from EPAC2 and shows trends in nitrofurantoin and trimethoprim use in the UK, and it highlights the change that occurred in December from December 2014, the National Prescribing Guidance started to recommend nitrofurantoin as the first-line antibiotic for women with suspected UTI. And there was a changeover with a gradual increase in nitrofurantoin prescribing and a reduction in trimethoprim prescribing. A study by Hammond et al. In 2020 looked at prescribing data from the southwest of England from 2013 to 2016. There were 163 GP practices serving 1.5 million patients. Team used logical regression to assess changes in resistance patterns and the association with prescribing rate changes controlling for confounding variables. And they found a fall in trimethoprim use by 8%, 8.46%, and a decrease in ciprofloxacin use by 24% between 2013 and 2016. There was an increase in nitrofurantoin use by approximately 7% over this period, but this was unsurprising because of the change in the national guidance in 2014. The odds of trimethoprim resistance and ciprofloxacin resistance were lower in the subsequent quarter as use declined, but increased nitrofurantoin dispensing was associated with reduced trimethoprim resistance and no significant changes to nitrofurantoin resistance. So it wasn't the case that we simply swapped over. We reduced trimethoprim resistance without changing the nitrofurantoin resistance. And with that change being 2014. So this study aimed to evaluate the associations between changes in primary care dispensing and antimicrobial resistance. It was a multi-level logistic regression modelling investigating these relationships, and it did show these significant changes, and there is a reference on the slide given here. So these were significant findings with the changes of resistance being reduced in the following quarter. So in 2022, there was a slight decrease in nitrofurantoin resistance reflected in national surveillance data, but otherwise resistance for trimethoprim and nitrofurantoin have been relatively consistent at around 30% and just under 2% respectively. This top graph is for trimethoprim and this second one for nitrofurantoin. This data shows that resistance is proportionally higher in the older age groups, which are, this is 0 to 18, 14, 65 plus. And it highlights the differences between male and female sexes. The data does not represent the data for all patients presenting to you with acute uncomplicated UTI. As we know, most GPs tend to only send urines to the laboratory for patients with recurrent UTI or persistent symptoms or particular risk factors. But it certainly gives us some indication of the greater resistance in the elderly. You can see the significant changes. So clinical outcomes of uncomplicated UTIs in English GP practices treated with empirical trimethoprim. So first, what's the evidence that antibiotic resistance is important in your day-to-day practice? Maybe you could consider when you last had a patient with UTI, reconsulting after treatment. This is a prospective study of 497 women aged between 18 and 70 years with at least 2 UTI symptoms. It looked at clinical outcome in acute uncomplicated UTI in women treated with empirical trimethoprim. Patients with a UTI resistant to the antibiotic in the this column, which is showing resistance to the trimethoprim, took twice as long to become asymptomatic compared to those with a susceptible organism. So you can see the medium time symptom resolution, 7 days compared to 4 days, and you can see the p-value here. Furthermore, 40% of those with a resistant organism reconsulted in the first week, compared to only 6% with a susceptible organism. In fact, half of those patients who reconsulted in the first week had a resistant organism grown from their urine, and the majority of these had further antibiotics in the first week. So resistance, which is this line here, so resistance is actually causing you work with further consultations. And at 1 month, 42% of those patients with a resistant organism still had the same resistant bacteria in the urine, and this would have been much greater, but 11 of these 19 patients had received a second antibiotic, and that's compared to 20% with susceptible ones. So McNulty et al. Studied whether patients with an uncomplicated community-acquired urinary tract infection and an isolate resistant to trimethoprim had worse clinical outcomes following empirical treatment with trimethoprim 200 milligrams BD for 3 days than those with a susceptible isolate. It was a prospective cohort study of women between 18 and 70 years presenting to GP surgeries in Norwich and Gloucester with at least these 2 symptoms. And the results showed that of the enrolled patients, 75% had significant bacteria, and trimethoprim resistance was present in nearly 14%, which is 44 of 317 isolates. And patients with the resistant isolates had this longer time to symptom resolution, greater reconsultation, more subsequent antibiotics, which is 36% versus 4% in the first week, and higher rates of significant bacteria. Half the patients reconsulting the first week had a resistant organism. So we've shown that resistance is important and is increasing, but does our antibiotic use cause increased risk of antibiotic resistant infections in our patients? And I'm going to show you a study that goes some way to show that. So Costello et al. Conducted a systematic review and meta-analysis examining previous antibiotic use and subsequent resistance. They included 5 studies of UTI with 14,000, over 14,000 patients in general practice. Found that antibiotic use in the past 6 months increased the risk of resistance basically 2 times, 2.18. This forest plot shows risk of having a resistant organism if patients had an antibiotic in the last 6 months. As you can see, the risk was increased in all the studies, as the odd ratios, the blue squares, are to the right of the line. So here it's showing increased risk of resistance, with confidence intervals that do not overlap that line. So the longer duration of and multiple courses of antibiotics were associated with greater resistance. And what's important to note is that resistance to one antibiotic, for example, amoxicillin or trimethoprim, can be linked to other resistance genes on the same mobile genetic element, so that you can select multiple resistance by use of any one antibiotic. So use of various antibiotics can be considered to increase the risk of other antibiotics, even if the initial choice can be a narrower spectrum. Narrow spectrum antibiotics can sometimes increase resistance to other antibiotics as well. Okay, so in conclusion, those individuals prescribed an antibiotic in primary care for a respiratory or urinary tract infection have an increased risk of developing bacterial resistance to that antibiotic. And I'm going to show you in this study the effect of antibiotic in primary care and antimicrobial resistance in individual patients shows that for those studies looked at with a UTI, the increased risk of a resistant organism if the patient had had an antibiotic in the past 2 months was 2.5 called odds of resistance, so an increased likelihood of resistance if the patient had received an antibiotic in the past 2 months. And that persisted even out to 12 months. So there's still a detectable 1.33 times increase in the odds of resistance. And so that tells you something about the duration of the disruption to the normal gut flora. It will persist for a year post an antibiotic course. And it actually is also consistent with some studies on C. diff, which show that the resistance, that there is an increase in the likelihood of C. diff for up to a year after a course of antibiotics, again reflecting the potential for the disruption in gut flora lasting that long. Which is an important point to note if a patient is coming to you for a prescription, wanting a prescription of antibiotics. Not so many patients understand that the risk of resistance to a subsequent infection lasts as long as it does, should they be taking antibiotics or antibiotics unnecessarily for an infection. Okay. So UTI management and shared decision making. The patient urinary tract information leaflet has been designed to be used during consultation with women who have a suspected UTI. It's a useful tool for clinicians to use, whether the patient needs an antibiotic prescription or not. It explains the treatment decision pathway and therefore is also helpful for less experienced staff. And it includes information on the types of UTI, which are often misunderstood by patients and healthcare staff, illness duration, self-care advice, prevention advice, and advice on when to reconsult. And this leaflet was endorsed by NICE to use with the prescribing guidelines. Target leaflets have been formatted into HTML text, so they're accessible using digital technology and screen readers. And the leaflet can also be linked to your computer clinical systems. For example, Accurex has embedded all of the Target HTML leaflets into their SMS services. So I'm now going to walk you through the various aspects of our leaflets for women under 65 years. So firstly, this part here deals with the possible urinary symptoms and signs. So the key symptoms and signs that we've already talked through, the other symptoms and signs to consider, and other things such as recent sexual history and changes during menopause. The outcome and plan can be personalised to include aspects of pain relief, whether there are backup antibiotics or immediate antibiotics, and when to use. There is an option here in terms of how to prevent UTIs. Simple advice and for patients, including hydration, including self-care, and this picture can help patients understand the cause of UTI and how it comes about. There is a comment as well on safety netting, including the use of cranberry products or D-mannose, and the use of vaginal estrogens, which the patient may want to discuss further. That is particularly useful for recurrent UTI prevention. And the flow chart helps patients understand antibiotics and resistance. So Target have a pictorial UTI patient information leaflet for UTI in adults of all ages that was published in March 2021. It covers the same information, but in a format that's easier to read. It's got larger text and it's got graphics. Here is the first page of this. What symptoms should you look out for? And what can be done to make you feel better in a way that is easy for patients to see and understand. And including when should you seek more urgent help, along with some contact information. So this is the Target website. This is where you can access the HTML version of the UTI leaflets. As discussed previously, this format is easier for patients to access using digital technology. It enables you to SMS or email this information to your patients. And this screenshot shows where the UTI leaflets are embedded in the SMS templates. So there is a table of contents that show the various different leaflets that are available. Here is how it can be adapted for particular patients. Okay, so while we're not going into detail regarding UTI prevention, before we go into management, we wanted to highlight non-antibiotic agents that can be used to prevent or manage UTIs. NICE guidance for lower UTIs reviewed the effectiveness of cranberry products, and no evidence was found to support or disprove the use of cranberry products. However, for some patients, they can be of help. There is a recommendation for the use of analgesia, paracetamol or ibuprofen, and the importance of drinking enough fluid to avoid dehydration. For recurrent UTI, the NICE evidence review highlighted the effectiveness of vaginal estrogen for preventing recurrent UTIs and indicated as a first-line method for management in postmenopausal women. For self-care, NICE state that some women with recurrent UTI may wish to try D-mannose, which is, D-mannose is the active ingredient in cranberry products, and cranberry juice per se is very dilute, but you can take cranberry capsules or D-mannose, which is the active ingredient. If they're not pregnant. The evidence for D-mannose was based on a study in which it was taken as 200 mils of 1% solution once daily in the evening. D-mannose is a sugar that's available to buy as powder or tablets and not a medicine as such. Though the benefit is uncertain, it can be helpful to some women. Some children and young people under 16 with recurrent UTI may also wish to try cranberry products with the advice of a paediatric specialist. Again, the evidence of benefit is uncertain. From the NICE website, NICE are currently reviewing the evidence of Hiprex, which is methenamine hippurate. And they state that this review may well go on to impact the guidance. We don't know when that will be or what will be the outcome, but some trusts do include the use of Hiprex within protocols for recurrent UTI management. And there are some double-blind RCTs looking at both D-mannose and Hiprex, with varying results. Again, I think it's something that it needs to be tried with women with a recurrent UTI to see whether it is a benefit for them or not. Okay, so moving on to antimicrobial prescribing for UTI. This is the NICE guidance, and NICE hosts the detailed prescribing guidance for women, men and children with suspected lower UTI, prostatitis and pyelonephritis, which was developed in collaboration with multiple stakeholders and is summarised in the decision tools that are linked to the main guidance. And the NICE guidance for the management of lower urinary tract infections, NICE suggests considering a backup antibiotic prescription or immediate antibiotic prescription for women, and noting that the evidence was backup was from women not needing immediate treatment. So the backup antibiotics would normally be a prescription to use within 48 hours if the symptoms either do not start to improve or worsen during those 48 hours for women with lower UTI and who are not pregnant. Obviously, what needs to be taken into account is the severity of symptoms, the risk of developing complications, which is higher in people with known or suspected structural or functional abnormalities, the genitourinary tract, or patients who are immunosuppressed for any reason. The evidence for backup antibiotic prescriptions, which was, as I say, only from non-pregnant women with lower UTI, where immediate antibiotic was not considered necessarily, and took into account previous urine culture results and susceptibility results, previous antibiotic use, which may have led to resistant bacteria, and the preferences of the women for antibiotic use. So that is hopefully something that you are familiar with, the advice that is down on the sheet from NICE. So backup prescribing from UTI is generally acceptable to patients, and we have some data from 2023. So 54% of the population are in favour of delayed antibiotic, and this data comes from surveys that target households asking about knowledges, attitudes and practices specific to antimicrobial use and the management of common infections. And the research is carried by a market research agency in February, March of each of the years indicated. Findings from 2023 showed that about 54% of the population support the prescribing of delayed antibiotics depending on the type of infection. In the last 12 months, 7% of the people in the survey had received a delayed antibiotic prescription. Of these, about 19% didn't end up using them. Most commonly, this was for a respiratory tract infection, cough, sore throat, ear infection, etc. But for 16%, it was for a UTI. There is stronger support for delayed antibiotics in response to a urine infection, 52% support, followed by an ear infection, 49% support, and a throat infection, 47% support. And consider backup rather than immediate antibiotics for UTIs using the guidance discussed on the previous slide, but make sure to explain rationale, pain relief, and how to collect the prescription. Just to say, the study came from over 5,000 adults in England in this particular one. So that's a graphic that basically shows the what I've just described in terms of support, and then 19% neither support nor oppose, and some that oppose or don't know. If backup rather than immediate antibiotics are given, it's important to explain the rationale, to give pain relief, and explain how to collect the prescription. So NICE prescribing for low UTI for non-pregnant women, the first choice is nitrofurantoin. That is if the EGFR is 45 or over, and preferably given as 100 milligrams of modified release nitrofurantoin BD. If modified release is not available, then 50 milligrams QDS of standard nitrofurantoin. If there is a low risk of trimethoprim resistance, then trimethoprim may be used for 200 milligrams BD for 3 days. You can use the patient information leaflet to discuss information on safety netting and self-care, as well as providing information on pain relief. And as seen previously, prevalence of resistance is higher in the older age groups, so it is recommended to send urine for culture if you're prescribing antibiotics. We'll discuss risk factors that may mean that you need to send the urine for culture on the next slide. So many studies have looked at resistance factors for resistance. Most relevant one for the community setting was undertaken in Scotland in 2016 using routine data. Results indicated that age, over 65, care home residence and increasing comorbidity were significantly associated with resistance after adjustment for other factors. Other studies have looked at risk factors associated with UTIs due to ESBLs, which is extended spectrum beta-lactamase producing coliforms. And risk factors identified included recent antibiotic use, residence in a long-term care facility, recent hospitalisation, age 65 years or older, male sex, travel to a country with high resistance rates, may be important for particular patients, especially if that country has poor hygiene, and for example in Southeast Asia or India. If there is risk of resistance, always safety net and send urine for culture and susceptibilities. So we talked previously about how UTIs are linked to bloodstream infections in England. Who can remember the present prevalence of co-amoxiclav resistance in England? Now, if we estimate the prevalence of E. coli bloodstream infections which are resistant to co-amoxiclav, there is a poll here, and you can should be able to see that on your screen and vote. What do you think is the most likely prevalence of E. coli bloodstream infections resistant to co-amoxiclav? So you've got choice of A, 0 to 10%, B, 11 to 20, C, 21 to 30, D, 31 to 40, and E, over 40. And you should be able to see the results coming up. I don't know how, are we still seeing a few more voting? I think we might be more or less there. Haven't seen many changes. Shall I show you the answer? So the majority of people have not actually got this right, because the answer is E, over 40%. It's 41.4% resistance. So obviously very highly significant. Reducing the 3C antibiotics, by which we mean ciprofloxacin, cephalosporins and co-amoxiclav, can help reduce the risk of development of resistance, but also reduce the risk of Clostridium or Clostridioides difficile for patients and community. And Clostridioides difficile, C. diff, is an important infection in primary care as well as in hospitals. People tend to associate it with hospitals, but increasingly we are seeing patients present in primary care with C. diff, and it is there's data to suggest that it is an under-recognised condition requiring some intervention. So remember that fluoroquinolones like ciprofloxacin are not recommended, and there's been a recent further alert if any other appropriate antibiotic can be used. NICE recommendations for lower UTI management in non-pregnant women don't recommend these broad spectrum antibiotics for first or second choice management. Instead, the use should be for nitrofurantoin first line, and if necessary, pivmecillinam, which is a penicillin, however, so it cannot be used in patients with penicillin allergy. If there's a low risk of resistance, trimethoprim can still be useful. Second choice would be pivmecillinam is second choice, 400 milligrams initial dose and 200 milligrams 3 times a day for a total of 3 days, unless you are known to be dealing with a multi-resistant organism, in which case it's 400 milligrams TDS for the duration. If the use in women is fosfomycin 3 grams as a single dose sachet. If there's no improvement in lower UTI symptoms on first choice taken for at least 48 hours, or when first choice is not suitable, these may be the time when these alternatives may be used. Now, there's a lot of regional and national variation in the use, particularly of pivmecillinam and fosfomycin, and your local microbiology laboratory may or may not give you susceptibility on these. So it's important to check your local guidance and follow the related recommendations. There is also some variability in resistance for different things across the country. Note with pivmecillinam, manufacturer advises to avoid in pregnancy, but should be appropriate for those who are breastfeeding. And apart from the penicillin allergy, it should also not be prescribed with those who are hypersensitive to cephalosporins, have acute porphyria, carnitine deficiency, or concurrent treatment with valproic acid or valproate, and any other medication liberating piperacillin acid due to the increased risk of carnitine depletion, or have gastrointestinal obstruction or strictures. So there are various interactions, including methotrexate, anticoagulants, and valproate. Whereas fosfomycin, generally well tolerated, can cause diarrhea, but is a single one-off dose. It's granules to be dissolved into a glass of water and taken. So NICE also provides prescribing guidance for pyelonephritis, upper UTI. The choices for non-pregnant women, men, and then pregnant women are summarised in these slides. The full guidance provides further choices for IV antibiotics, and see the BNF for appropriate use and dosing in particular populations, for example, hepatic impairment, renal impairment, and breastfeeding, and administering the IVs. It's always important to check previous urine culture susceptibility and prescribing in anybody who's relapsing with symptoms or has a reinfection, and choose antibiotics accordingly. The updated MHRA regulation about fluoroquinolones needs to be considered before Cipro is used, but it is a good option in acute pyelonephritis, which is a severe infection. And NICE are currently reviewing guidelines that include fluoroquinolones as a choice. Intravenous antibiotics should be reviewed by 48 hours and consider stepping down to oral antibiotics, and one would hope that there may be some susceptibility testing results to inform on that. And therapeutic drug monitoring and assessment of renal function may be required. So here are some other resources that are available or linked to the Target Toolkit that may provide more information about UTI management. There is a rapid update quiz for clinicians who manage patients with suspected UTI that you may be able to do in your surgeries. There is a podcast. There is a non-medical staff, there's an animation that is aimed towards non-medical staff on to dip or not to dip, whether to use dipsticks or not, and that's on YouTube. I don't know whether you've done any personal or practice-wide antibiotic audits in the last year, but this can really help you understand what antibiotics you and others in the practice are prescribing and to whom and why. The Target website has audit templates with appropriate guidance and read codes to use for otitis media, sore throat, acute cough, as well as the UTI audits. And for the UTI audits, there are audits for the under 65 older adults and those with catheters. And this will help you with CPD. Okay, I am now going to, so that's actually all that I have to say on target UTI, and I'm going to now hand over to Elizabeth Beach to talk about routine data for UTI improvement. Elizabeth.
Sorry, I'm just unmuting myself and putting on the video. Thanks, Philippa. So very quickly, this is just to give you a bit of a heads up, not going through the routine data for improvement dashboards, but to let you know they're there. And you can contact your NHS England Regional Antimicrobial Stewardship Lead if you want more information on where to find this data. If you can't click the links through the slides, which they are in the slides, and if you want help with how to use the data dashboards. Next slide, please, Philippa. So first of all, we have the NHS England Model Health System, AMR dashboard, which contains a number of infection pathways, but the urinary tract infection pathway has probably got the most activity because this was the pathway that we launched this Model Health System product with. This is accessible to anybody with an nhs.net email, and it used to be called the Model Hospital System for those of you who don't recognise it. And it is worth probably registering with Model Health System and then having a look. This is a population health dashboard, and it is reporting at an integrated care board or integrated care system level only. So it's not going down to GP practice PCN level, but it's very helpful for your system because it includes an awful lot of data. As you can see there from this screenshot, it includes data around antibiotic prescribing in primary care, primarily in older people, catheter prescribing in primary care, all ages. It's got the E. coli drug bug sensitivity data pulled over from fingertips. It's really easy to access it in this product, but it's also got inpatient admission data, and it's got those gram-negative bloodstream infections that Philippa was talking about. And it provides a lot of this data drilled down to gender and age bands, so you can really get a bit of a sense of the number of people that you might be dealing with. And it is looking at variation from a population health perspective. So you can see there on this slide, these are all 42 integrated care systems for whichever metric was selected, and it shows you what that extent of variation is. And obviously this is helpful because it raises questions about, do we need to go and find out if we're at one end or the other end of that variation ski slope. But you can also look within your system for variation between genders within your own system. And in the Southwest, we've identified really quite a lot of variation between males and females. And there seems to be really high burden of UTI, high burden of our gram-negative bloodstream infections, high burden of urinary catheter use, both indwelling and ISC in men. And we are really seeing some real health inequalities centred around men in the Southwest region. Since this slide was produced, the Model Health System has been updated and now includes a section for UTI in people with dementia, and that's really quite helpful. And coming soon, we're going to have a lot more information about antibiotics that are prescribed for the treatment of recurrent UTI based on low-dose antibiotics recommended in NICE, including methenamine as well. And these are population metrics, so they allow you to compare proportion of use in, for example, women aged 70 plus over the population registered with a GP list size in your system. So it's a very, very useful dashboard, and it does include other infections pathways as well. Next slide, please. Aligned to the Model Health System dashboard, we also produced at the same time, both these products were set up in 2019 to support the 2017-2019 focus on improving the management of UTI in older people in primary care, when we promoted the nitrofurantoin first option, and we try to reduce particularly the use of trimethoprim in older people where, as Philip has pointed out, the E. coli resistance is particularly high. We have an EPAC2 dashboard. Now this picks up purely on the primary care prescribing metrics, and this does drill down all the way down to GP practice level. So this is really useful for people working in PCNs and GP practices because it will actually provide you with your local data. And included, it has a metric which identifies the account of people who have trimethoprim prescribed more than once in any 3 consecutive months. And this aligns to the NICE guidance to avoid empirical trimethoprim use in people who would be considered high risk of resistance, and having trimethoprim more than once in any 3 consecutive months will be one of those factors. And this actually allows you to contact the BSA and get the NHS numbers for these patients, so you can do a structured medication review in your PCN or your practice if you want to review those patients and check that their care is appropriate. Next slide, please. But this dashboard is being replaced, and we're working on this at the moment with an even shinier, smarter dashboard. And this dashboard has been extended so that it covers the whole population, not just people aged 70 plus, and it will allow users to select by both gender and by age bands and by antibiotic to look at population health metrics, and it will be reporting people who are being prescribed these antibiotics. It might be methenamine you're interested in women aged 45 to 65, and it will allow you to look for variation across the organizational level that you're looking at, and this will drill down from England level again all the way down to GP practice level. It's also got the trimethoprim, recurrent trimethoprim use metric included in it, but it's also added in a recurrent nitrofurantoin metric in a similar way, and this will help support the recent MHRA drug safety update, focusing on the risk of long-term use of nitrofurantoin in terms of pulmonary fibrosis and liver disease. So in the same way, you'll be able to identify those patients through contact with the BSA. Next slide, please. And that's me finished.
Thank you, Philippa and Elizabeth, for some excellent talks there. We're slightly over time, but we have permission to stay on until 1:45. So we've had some really engaging conversations. So some really, many of the questions have already been answered in the chat. So we'll not go over those that have already been answered. But we do have some questions for the panelists. We've been sitting here writing them down. So my first question is for Lee, actually. What are the differences in UTI management in Wales? Are there any differences? Lee, or
yeah, you can hear me. Yeah, so no, not really. I mean, I think the challenges around diagnostics and things is the same in Wales. The only slight well, it probably isn't that different. We've got kind of local prescribing guidance depending on which health board you're working. So yeah, not really significant changes.
Fantastic. And I'm going to specifically respond to Alison, but I'm going to ask you, Avril, rather than just type in the answer. How do we access prescribing data in Wales? It's fabulous that Elizabeth has presented prescribing data for England, but how can Welsh colleagues access prescribing data in Wales?
So the Prescribe dashboard contains Welsh data. So that is a useful one to look at. Also Public Health Wales, through their their HARP programme, produces frequent data, which you can, if you contact Public Health Wales directly, I'm sure you can get onto the circulation list for that. It comes to health boards regularly and is used as benchmarking and tracking for antibiotic prescribing within Wales. There's also other systems that you can use if you are clinical. So I do believe Alison said that she was a Welsh GP. So linking in with the medicine management team, you can have access to CASPA data, which looks at dispensed antibiotics. That can also be a really useful place. Also the AWTTC, All Wales Therapeutic and Toxicology Centre, has a SPIRA dashboard, which is got really good functionality, which you can drill down to even down to a practice level or cluster level, or indeed the Welsh Health Board that you want to look at. And it's very useful at being able to benchmark to other practices. So that there are lots of things available, and they are predominantly from Public Health Wales or AWTTC with that.
That's fantastic, Avril. Thank you. What we'll do is we will collect some of this information, because that's a lot to run through and for people to remember. So we'll collect some of the information from you, Avril, for some of the different options. From Elizabeth as well, we'll get some key points, and we'll make sure that they put those in the Q&A and the FAQs that we put up on the Target website with the webinar as well. I just want to double check. I know Naomi was having some technical difficulties. Naomi, are you still there or have you gone?
I am still here, just hanging on in there.
Okay, fabulous, Naomi. The question we had was, sorry, I've lost the question. Pharmacy first. How will we look at tracking prescribing for UTI through the Pharmacy First program? Can Naomi or
I think I'm probably better suited to answer that because I'm leading that piece of work. So we are working with the ECBSI to produce an antimicrobial stewardship Pharmacy First dashboard to go along with our existing other 3 antimicrobial stewardship dashboards on the EPAC2 system. And this will report in the way we do with all of our other dashboards, organisationally down from England to region to ICB to community pharmacy, providing information on the activity for all 7 infection pathways. We also have an ambition to be able to add the consultation that's resulted in the supply of a medicine for any of the 7 infection pathways, because we know the patient NHS number, we know their GP, to repatriate that to the GP organisational data in EPAC2 with a field that says it's a pharmacy first consultation. So that will support surveillance within integrated care systems in the way they currently use EPAC2 data to analyse surveillance of antimicrobial prescribing.
Okay, fabulous. Thank you, Elizabeth. And then there was a question. I'm going to ask this to Philippa, actually. Any thoughts on 3 days nitro not being sufficient for women? I have heard GPs report this.
So I think that for young women with a UTI presenting to a GP, there's no evidence that 3 days is not sufficient. NICE ask you to have a look at your patient if they're immunocompromised. If you've got complications of the patient, then actually the evidence may be for a longer course, and that is within the NICE guidance. For patients that are with recurrent UTI, and this is obviously a slightly different group, then there is something about how that individual patient has fared in the past. So if you've got someone with recurrent UTI who has not improved on 3 days of nitrofurantoin in the past, then they may be, and this is generally elderly patients whose immune systems are not working terribly well, may have a complication, then they sometimes may need more than 3 days. What I am aware is the NICE guidance basically jumps from 3 days to 7 days. And I think that there are a group of elderly patients who probably don't need as long as 7 days. But certainly for young women presenting with, most women basically presenting with UTIs, then actually 3 days of nitrofurantoin is sufficient. It's always important to remember as well that eradicating the organisms from the bladder to treat the UTI is a quicker process than sometimes actually the patient's symptoms, which can be related to inflammation, resolving. So sometimes symptoms can take a little bit longer than the infection, but so the remaining symptoms may take a few days longer than the antibiotic course, but will still resolve, assuming that their patient is sensitive.
Okay, brilliant. And Elizabeth, I noticed that you had said that you'd like to answer this question as well. Do you want to come in? Is there anything you want to add to that?
Had I?
Okay, maybe not.
I think that was my technological ineptness, probably. I think it is worth mentioning, though, that a lot of the European countries do tend to use nitrofurantoin as a 5-day duration, and that's a sort of historical duration that they use. But I think there is, if there really was a lack of effectiveness with a 3-day treatment duration, we would have much higher rates of pyelonephritis, given the vast quantities of 3-day nitrofurantoin that we do use in England. Sorry, can't talk about Wales.
No, that's fine. We had a question earlier. Will we be discussing prophylactic use of antibiotics for recurrent UTIs in this webinar? I think Emily responded to say, no, not in this webinar, but we do have the that the RCGP will be sending out the survey after that. And I do believe that was one of the options for a future webinar. Would anybody be interested in that in a future webinar, amongst other webinar topics as well? So do please access that, fill it out and send it back to us, because it really does help guide us as to identify what sort of webinars you would like in the future. I think that is all of our questions answered at the minute. So it is 7:45 now, so we're going to stop the webinar at this point. Thank you all 197 of you who have stayed for the extra 15 minutes. It's really appreciated. Thank you for coming, and a huge thank you for the panelists and the team in the background for putting all of this together. We've had some comments already saying it's been really informative. I think people have valued the webinar, so we'll share the feedback later. And thank you for everybody who's attended.